typhoon to mess with the well-laid plans, but I thank you all for coming out this morning, especially given the weather. My name is Linda Weatherby. I'm a patient advocate, and I'm one of the co-chairs for today's event. And I welcome you to the inaugural Northwest Metastatic Breast Cancer Conference. This has never been done before in Seattle, and I will go through thank yous today because we have a lot of people to thank for that. For all of you that came, thank you for paying attention, and we're going to send you home with some really important information. First off, I want to say that we had almost 175 people register for today's event. I'll share a little bit about what the breakout is there. We had 75 people identify as metastatic breast cancer patients. We have about 19 caregivers. We have 39 who said that they're not metastatic, but they wanted to stay informed. We had about 20 others, which is staff and sponsors, but we were really thrilled with that response. It's tough to get an event off the ground and get it out there, and we would certainly appreciate your help in promoting this over social media today and going forward, and we hope to make this an annual event. Back of the agenda has the social media information and the hashtag, and I also want to say that we are so lucky to be able to broadcast over Facebook Live this morning. If you know someone who would be interested in this information and couldn't make it, or somebody in another state, please text them, let them know, and we should be up and ready to go. As we start, I hope you'll indulge me. I want to share just a little bit about how all this came about. It's kind of interesting, especially since it hasn't been done before, and that involves just a micro version of my own story. And I want to say that I learned that I was metastatic in May of 2013, and that was 12 years after my first diagnosis of breast cancer. And we thought at the time that it was a stage 0 DCIS. I had a bilateral mastectomy and went on with life, raising a preschooler and kindergartner, and thought it was good. And then my world sort of dropped out of its orbit when in 2013, after a few years of not feeling well and not knowing what was wrong and having weird symptoms with my eyes and my digestion and my bones, things that should have triggered me to look into what might be going on, I got the diagnosis that my earlier stage 0 breast cancer had metastasized to my bones and to my spine, to my brain, and to my trigeminal nerve. And if you don't know what a trigeminal nerve is, count yourself lucky. It was a very, very difficult thing. And I'm doing really well today, and that's because of some wonderful doctors who will be here today, including Julie Grable. And I'm really, really grateful for their care. As all of that was happening in 2013, I was blissfully unaware of some metastatic breast cancer facts. Since I had a really good prognosis in 2013, we thought that my 5-year risk of recurrence, or 5-year survival or risk of recurrence rate was about 2 to 3%. And I didn't ask a lot of questions beyond that. That was good for me. And I certainly had no idea what my lifetime risk of recurrence was. I realized in a nanosecond that it wasn't my fault. There was nothing I had done that brought this on, and there's nothing that you've done that's brought this on. This is a really big dynamic. It affects a lot of people, more than any of us really understand. I also didn't know at the time that only about 7% of research dollars for breast cancer are directed toward metastatic breast cancer research. And actually, if you're really specific, it might be even less than 7% that actually benefits metastatic breast cancer patients. So the data is very difficult to measure. It's being hotly debated. But the main point is there's far too many of us living with metastatic breast cancer and not enough resources for metastatic breast cancer research. And the people who are in this room today and who are going to speak today are working on it, and they're the ones to talk to. And if you stay all day, you're going to be leaving very educated about how we can change that and lend our voices. I want to say that have a really great co-chair for today. Her name is Beth Caldwell. Beth, you want to raise your hand? Many of you know that. She is on fire to change those statistics. She is the founder of co-founder of Meta, and she'll explain more about this later today. We first met through a metastatic breast cancer support group here in Seattle. 4 of us met that day to share ideas on how to change things and hopefully make a difference. And I think that was about a year and a half ago, and only 2 of us are still here working on those ideas. We talked about the need for a metastatic event in Seattle and how it had never been done before. And then this summer, Pfizer Oncology stepped in with a grant with money for just such an event. And one thing led to another, and the wonderful people at Come and Puget Sound stepped in and worked with that grant money and pulled all of our other sponsors in, and we're all sitting here today. So if you're talking with our sponsors and Come and staff today, please tell them thank you for what has transpired. And Beth, I want to say thank you to you for your leadership and your commitment during active treatment, which she will tell you about later. It's really incredible what you're doing, and you go, girl. We also want to thank our planning partners at Come and Puget Sound, and there are people that I really want to call out here because they have just gone, to great lengths to make today happen. First, Robin Sneeringer, and Stephanie Yankee, Christy Balloso, Dawn Sanders, and Marcia Samuel. They're all in the room. Thank you, thank you, thank you. And to David Richard, the Executive Director of Come and Puget Sound, we want to say a big thank you to him because he invested in this event. Actually, they didn't do their normal fall luncheon and instead invested the time and energy into this event, which is a first. And we want to thank David for leading the way among Come and affiliates everywhere. A huge thank you goes out to all of our sponsors. The Northwest Metastatic Breast Cancer Conference is supported by Susan G. Come and Puget Sound in partnership with Swedish Cancer Institute, Asai Incorporated, Fred Hutch Cancer Research Center, Medivation, Pfizer Oncology, and Seattle Cancer Care Alliance. We're asking you all to please stop by their tables. They're in the hallway, and then there are some overflow tables set up in room SDE. Is that how we pronounce it? Yes. Okay. We also want to say a huge thank you to our advocacy partners who are here, and I'm personally very excited about this part of our agenda today. Many of them just flew in from DC, and they were on Capitol Hill on Thursday for Metastatic Breast Cancer Day, lobbying and doing, I don't want to steal their thunder, they were doing some amazing things, and I hope that you'll stay for the last session of the day to hear all about that. And that is the Metastatic Breast Cancer Research Project, Metastatic Breast Cancer Alliance, MetaViver, Sierra Sisters, Metastatic Breast Cancer Network, MEDUP, Living Beyond Breast Cancer, YSC, the Young Survival Coalition, Harmony Hill, a retreat center, and Cancer Lifeline. Their websites are full of information. If you haven't been there, go there. And another shout out goes to our medical advisors for the day. Dr. B.K. Gotti and Erin Ellis gave great input on our program design. And a heartfelt thanks goes to Julie Graylow, who went above and beyond all the way from day one to help us get this day organized. We would not be able to do it without you, and we've got you down for next year. Yeah. And to all our speakers, thank you so much for being here. Really, it was amazing. When we put the ask out, everybody said yes. So if you're interacting with our speakers and doctors, please tell them thank you for doing this. I am running late, so I'm just going to close by saying that lunch is from 12:45 to 2 o'clock in the Double Helix Cafe. We've given time for an extra break there. Please take other breaks as you need to today. We know it's a jam-packed agenda. And we're going to let you know about the reception at the end. Given the weather, we may move the reception up a little bit and let you enjoy some of those, some of the food and drink while we have the advocacy session. And that is my time. I will introduce our first speaker to kick things off. Dr. V.K. Gotti is a medical oncologist who specializes in caring for patients with breast cancer at the Seattle Cancer Care Alliance. The focus of his interactions with patients is providing information for cancer care options that work best for patients and their loved ones. He cares for patients at SCCA, and he is Assistant Professor of Medicine in the Division of Oncology at the University of Washington School of Medicine, and Assistant Member in the Clinical Research Division here at the Hutch. And he is a poker phenom. Please get us started, Dr. Gotti.
Thank you, Linda. I'm going to go through your slides. Okay, so today, the way we were thinking about this conference is to first set the stage of where we are, and you're going to have a series of speakers talking about the different kinds of metastatic breast cancer. I think most of us think, or at least in the public, think breast cancer is one big giant thing, but those of you who have it, deal with it day to day, know it's not. It's very different from one patient to the next. And we try to cluster these patients into certain groups and think about these problems as discrete problems that we can attack with different kinds of medicines and strategies. But before we even get that far, I think it's important to know what is the toolbox? What are we using these days? So that's what I'm going to focus on in this first 10 minutes or so. And here we are. That's me. And if you haven't done so yet, this is the Fred Hutch, and the Seattle Cancer Care Alliance is down the street, and we're all part of the University of Washington as well. This is a phenomenal place, ground zero for a lot of cool research. I think if you walk by the Nobel Prizes on the left, that should be one indication of such a thing. So the treating team, so I like to think of this as a 5-doctor problem. So where is it? What is it? So that's our pathologist. Cutting it out, I found a random surgeon, I don't know. Zapping it, and this is what our radiation therapists do, and then poisoning it, and that's what a lot of the medical oncologists do, right? And then within the medical oncology community, I think about having 3 toolboxes that we have access to. The first is chemotherapy. So what is chemotherapy? Unfortunately, many of you know what it is, but really, at its core, it is poison that kills things that divide rapidly. And in a woman with breast cancer, oftentimes the most rapidly dividing thing in her is cancer cells. And that's why chemotherapy can work. But for the very same reasons, chemotherapy hurts. And you have other things that divide in you. And many of you know, like your hair grows, right? Well, that's one of the things that falls out sometimes. Fortunately, it recovers. Similarly, the cells lining your mouth, your esophagus, your stomach, your whole GI tract from beginning to end is filled with dividing cells. And over time, things like mouth sores, nausea, vomiting, heartburn, constipation, diarrhea. I see a lot of you nodding your heads. You sound familiar, right? And then the other thing that we really worry about a lot with chemotherapy is your bone marrow. Your bone marrow has about 300 billion cells a day that are made actively. And with any chemotherapy, that's going to get diminished. And so many of you have experienced a low white count, right? Many of you experienced anemia because you're not making enough red blood cells. Many of you have had problems with your platelets so that you bruise easy or you bleed easily when you're brushing your teeth or something like that. These are common toxicities of all chemotherapy. And what you're going to hear about is some ideas of chemotherapy moving forward, but really the chemotherapy innovation has been very, very little in the last several years. There's been only a handful of new drugs, and a lot of the poisons we use were developed around World War II, and they're coming forward. So they're not a lot of innovation there. Where we've really innovated is to be able to protect women from those toxicities. So it's unacceptable now to have to deal with nausea and vomiting. And if you are, we as a medical community are failing you. We have plenty of medicines to help you in that regard. And similarly, we can't have people having a low white count, getting a simple infection and dying from that. So what do? We give you a white blood cell booster shot. So in this way, we can kind of manage those toxicities, but at its core, chemotherapy is poison, and the intent of that poison is to kill things that divide rapidly. The other toolbox we have access to in breast cancer that a lot of other cancers don't have access to is what we call endocrine or anti-hormone therapy. So a lot of breast cancers, maybe 60% of them, are born caring about one thing and one thing only, and that's estrogen. So we know at its core, if we can attack estrogen in a woman's body so that the cancer cells don't have access to it, then those cells will struggle to survive. And there's been a lot of innovation here as well. Over the last few years, we've had not only medicines that directly attack the estrogen receptor, destroy the estrogen receptor, starve the estrogen receptor, but in those cancer cells that don't care about estrogen anymore, we've now worked out workarounds to maybe get them to care about estrogen again. And these are some of the therapies you're going to hear about in the next few sessions. And then this is our favorite therapy. This is what people fly all around the world trying to get in get their hands onto, and these are what I call engineered therapies. These are biologics and immunotherapies. So these are not things that grew in a tree, we didn't find it in the soil. These are things we engineered from the ground up. We found a problem in a cancer cell that was unique to that cancer cell, not really present in the rest of the body, and we went off and designed therapies for these things. And they are just legion at this point. There's a ton of these medicines. They work very differently from each other and have the worst names ever. They end in nib and mab, and some of them have 2 words in them. It's just terrible. But really, these are where all of our hopes lie. And now we're getting to a point where we're not using them one by one, but learning how we can safely combine these things so that we don't have non-overlapping toxicities from 2 medicines and can safely give them, and maybe there's going to be even more promise coming out of that. So combinations are the key. So know your enemy. Fighting cancer is like going to war, and what do you get when you go to war and with bad intel? Does anybody know? Political statement. You get that. No woman should be a rat. We should be going in with what we know to make the best assessment for that patient. So if you haven't had your tissue biopsied in a while, it's important to go get it biopsied. If it's safe, most doctors should be offering this. Because it turns out these things change. Cancer cells are wily. Whereas they once cared about estrogen, when they come back, they may not. Or it's not uncommon. Even this past week, I've had 2 patients who flipped their HER2 steps. In other words, they started off with HER2 negative disease, and then their metastatic tissue, they now have HER2 positive disease. And that's something we want to know because we can target that. And then make sure you're treating disease, not artifacts. If the scan is sort of iffy and you don't know what's going on, I think we owe it to our patients to really investigate that carefully. Sometimes it involves a biopsy or even just calling a different doctor and talking to them on the phone to make sure that what you're treating is the right thing. The last thing we want to do is treat things that aren't cancer either. And then make sure your doctor and you are fighting your cancer without a scorched earth policy, right? Because this is anytime we kill cancer, and to some degree it's a pyrrhic victory. The last thing we want is somebody feeling so poorly from what we've done that really where we put them is a far worse place than their cancer put them. So we have to be thoughtful about that. And that takes considering the tempo of the disease. If it's something that's growing very slowly, then maybe not the best choice is chemotherapy, but it's one of these endocrine or targeted therapies. And taking that into consideration is very important.